Good evening, and welcome to Pasadena City College. My name is Jo Bushko, and I direct student health services here at PCC. We're so glad to have all of you in the room tonight with us. Our first order of business is to recite the Pledge of Allegiance. Please stand and speak along with me. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. We're here tonight to talk about a crisis that many in our community are experiencing on a deeply personal level, with impacts across a wide range of compassionate care. While our community has not seen opioid strike as severely as they have in other areas of the country, addiction and mental illness are very serious issues in the San Gabriel Valley. We must all be vigilant to help our friends, neighbors, and families. I'm pleased to see so many partners in the room tonight to help address these problems. And now I'd like to welcome one of those key partners to the podium to help get our program started. She has long been a champion for our area and has dedicated considerable attention to the people in our region who need it most. Please join me in welcoming one of our leaders in Washington, Congresswoman Judy Chu.
Thank you so much, Ms. Busco, and thank you for hosting us here at Pasadena City College. This is a great venue for us to deal with this very, very important topic. And thank you all for coming out. What a great attendance we have tonight for a very, very important topic. Thank you all for being here to learn how to help loved ones who are struggling with addiction. And first, I'd like to thank our incredible panel of experts who are joining us. They are bringing a wide range of experiences in identifying, treating, and assisting in addiction recovery. And I know that they will have a lot to contribute tonight. I'd also like to thank our moderator, Ryan Hampton, Ryan right here, who is one of my incredible constituents and a truly inspiring recovery addict. Last year, he came to my office and he just had so much to say about what we needed to do to deal with the opioid crisis. And ever since, we've been partners in dealing with the issue. And I thank you, Ryan, for bringing to me so much of the knowledge about what's going on with the recovery community. And it was last year when he told me about this terrible story. He said that one of his close friends, Tyler, died. Tyler died in a sober living facility because no one on staff knew how to recognize the signs of an overdose. They didn't even have naloxone on hand, which is a common emergency overdose treatment medication. Ryan says this is an equivalent to an ocean liner not having lifeboats. So Ryan decided something had to be done, and he asked for a meeting with his member of Congress, and that was me. Well, that meeting really moved me. I said, I have to do something about this. And so we built a new partnership between us, one that led to the introduction of legislation, H.R. 4684. This is my bill on ensuring access to quality sober living. This bill would allow the Substance Abuse and Mental Health Services Administration, or SAMHSA, to develop a set of best practices for sober living facilities and provide technical assistance to states that wish to implement these best practices. Implementing these steps will help the patients and the families know which recovery residents uphold quality standards, and the standards will include requirements like having a strong peer support network, having naloxone, the anti-drug overdose, on hand to prevent deaths like Tyler's and other things. And it will allow families to have confidence that their loved ones are in competent hands. Well, Ryan is our superstar. Last week, he came to Washington, D.C. to testify at a very powerful committee, the Energy and Commerce Committee, on this bill, H.R. 4684. And as one of the only individuals in recovery to testify, he made the point to my congressional colleagues that recovery is often forgotten when we talk about the opioid crisis. Yes, prevention and treatment are critical components to addressing this crisis, but we cannot stop there. We need to address the recovery process as a nation in order to prevent relapses and to ensure that our loved ones maintain a successful recovery throughout their lives. So, Congress is finally starting to recognize how serious this crisis is. And it is finally increasing funding for treatment and recovery programs. In the spending bill that was just signed by the president just this last Friday, an additional $3.3 billion was included to address the opioid crisis. And that includes state grants for opioid response, money for the National Institutes for Health to expand our understanding of how addiction and recovery works, and monies for the Centers for Disease Control for opioid prevention efforts, and additional programs to help populations like veterans who are impacted by this crisis. But the most important work happens right here, right in our communities, and that's why we're here today. We want to ensure that families are prepared from day one to spot the signs of addiction. I've heard from so many of my constituents about how families are struggling to build effective support systems so that their loved ones can deal with addiction. So that's why we convened this workshop today, so that we can learn from experts who not only have direct experience in treatment and prevention, but also in the methods that family members, neighbors, and the community at large can work to prevent overdose deaths. So we hope that today's event can be a resource for all of you here today as we fight this epidemic in our own backyard. So please ask questions tonight, learn from each other, and together we can work together to help those suffering from addiction begin their road to recovery. So thank you all so very, very much for being here.
Thank you, Congresswoman Chu. It's a pleasure to be here. My name is Ryan Hampton. I'm a person in recovery from addiction. What that means to me is that today I'm able to be a son, brother, a friend, member of my community, a voice, as you stated last week, and most importantly, it also means I haven't felt it necessary to have a drug or a drink or any other mind-altering substance since February 2nd, 2015. Thank you. And I'd like to thank everybody for coming out tonight. You know, this is such an important issue. It's an issue that's very personal to me. Opioids take the lives of 174 Americans every single day. Stigma has kept many people from asking for help and leaves many people suffering in silence, such as I did for well over a decade. And it's events such as this town hall that will help open doors for people that need help, help start those important conversations that will help it happen at dinner tables. But before I introduce our panel of experts, I do want to say something about Congresswoman Chu and just acknowledge the work that she has done on behalf of our community on this crisis. As she said, I first met her about 2 years ago. I was getting ready to travel the country on this kind of nationwide tour. I had decided with my best friend who's here, we wanted to see what was happening in other communities, see how they were dealing with the opioid crisis, and seeing what recovery options were. So one of the first things we did is we contacted Congresswoman Chu and told her about our mission, told her about what was going on in the community, told her about the recovery community here, and she said, I have to come see it for myself. I, at the time, was living in a sober living home here in Pasadena, California. And the Congresswoman, unlike other policy leaders that we had reached out to, took the time to come and visit with us. She listened to the residents on our sober living. She saw them and saw us as not just as addicts, but as constituents and as people with a voice. And most importantly, she took time to learn from us, which is a lot more that I can say from some of our public policy leaders. As Congresswoman Chu stated, past October, I lost a good friend of mine to an overdose in a sober living home. The sober living home did not have naloxone on site. I was outraged as a result of this, but it was kind of the tipping point for me for something that had become a common theme in our community. Unscrupulous operators, unethical centers, unethical sober homes, people that aren't trained how to deal with overdoses, widespread abuses and neglect of people who were looking for help. Basically, there was no standard of care. There was no standard of care here in our community, but there was also no standard of care anywhere else around the country. Finding good help was basically a guessing game. And Garrett and I, who's here, went to meet with the Congresswoman. We told her what was happening. We offered a path forward. And together with our community, we helped write H.R. 4684, which is the Ensuring Access to Quality Sober Living Act. This is significant. When it is passed, which I hope it is passed and signed into law by the President, this critical piece of legislation will be the first time ever that there is a national standard of care for how a qualified, ethical, and stable sober home should be operated. It will get this information to the states so that regulations will finally begin on a state level. And at the bottom of all of this, it will save a lot of lives. So I just want you to know that Congresswoman Chu and the way that she worked for us in our community, in my opinion, is how good government should work. She was able to see past the stigma and see us for really who we are, which is people. And so thank you, Congresswoman. Thank you for the work that you're doing. Now I'd like to introduce our panel. Very excited about this panel. We have Dr. Gary Tsai, who's the Medical Director and Science Officer for LA County Substance Abuse Prevention and Control. We have Leah Rodemick, who is the Chief Executive Officer of CASA Treatment Center. And we have Theo Krasierski, who is a paramedic and founder of End Overdose. First, we will be introducing Dr. Gary Tsai, who will be talking about the opioid crisis and identifying signs of addiction in loved ones. Gary Tsai is the Medical Director and Science Officer for the Substance Abuse Prevention and Control Division of the Los Angeles County Department of Public Health. He is board certified in both general adult psychiatry and addiction medicine and continues clinical practice at Cedars-Sinai Medical Center. Having experienced the stigma and criminalization that often accompanies serious mental illness, as the son of a mother with schizophrenia, Dr. Tsai is a passionate advocate for improving our behavioral health systems. In his pursuit of meaningful change, Dr. Tsai is also the founder of Forgotten Films, the film production company focusing on social issue projects, specializing in behavioral health. Its first film, Voices, premiered on public television in May 2015 for Mental Health Awareness Month and was awarded a 2016 SAMHSA Voice Award. Please help me welcome Dr. Tsai.
Good evening. Can everyone hear me in the back? All right. I want to thank Congresswoman Judy Chu for having me here today, Ryan for introducing. Appreciate the opportunity to be able to speak with you all. I was asked to really focus on two things tonight. One is to give an overview of the opioid crisis, and two, to provide some information about how people can identify signs and symptoms of addiction in their loved ones. And so those will be my two focuses today. How many folks in the room would say that they're pretty familiar with, have read a lot of articles about the opioid epidemic? Okay, so that's probably the majority of people in the room. So this clearly is an issue that's been getting a lot of attention, a lot of press recently. One of the reasons is because it's one of the most challenging, biggest epidemics that have impacted us in a long time. Particularly in areas of the country such as New Hampshire, West Virginia, Kentucky, this is truly a growing public health concern that we need to pay a lot of attention to, including here in California. Just to start off with a little bit of data to help us frame the issue. So on an average day, that probably is a better viewing experience. On the average day, 115 Americans die from an opioid overdose. Between the years of 2000 and 2016, 600,000 people across the U.S. have died from drug overdoses. The summary of this is that this is an issue that impacts thousands, hundreds and thousands of people. This is perhaps my favorite slide when giving presentations about the opioid crisis. And so what I want to highlight here is that the United States comprises about 5% of the world's population. We consume 80% of the world's opioids. When you look at hydrocodone, which is the active ingredient in Vicodin, we consume 99% of the world's hydrocodone. And so what this tells us is that either Americans have more pain than the rest of the world, or this is a cultural issue where we use opioids in different ways more often than the rest of the world. And I think that's a really important take-home for reasons that I'm going to highlight a little bit later. Drug overdoses have surpassed motor vehicle accident deaths and firearm injury deaths in LA County. You can see the breakdown in terms of the impact of prescription opioids, which is RX opioids, heroin, as well as other drugs. And so opioids comprise a significant proportion of the overdose deaths in LA County. We've seen increases in terms of emergency room visits related to opioids, as well as hospitalizations. Since, between the years of 2005, 2014, so the past 10 years or so, we've seen some increases in terms of those. What's interesting is that the average opioid overdose death rate in LA County has maintained relatively stable during that 10-year period, at around 400 deaths or so a year. And what that tells us is that, number one, this is a growing problem. Number two, luckily, the increase in ED and hospitalization visits haven't translated over to overdose deaths yet, but it's a reasonable assumption that eventually those will, and that we need to intervene now in order to prevent future opioid overdose deaths. Wanted to just highlight this slide before moving on. This is an overview of the prescriptions that are filled in LA County. And so you can see opioids, about 44% of prescriptions in LA County are opioids, significant number. Sedatives, I wanted to highlight, sedatives being things like benzodiazepines, like Ativan, Librium, Xanax. Sedatives are a close second in terms of the number of prescriptions being prescribed. And this is true not just in Los Angeles County, but throughout the country. And the reason why I want to highlight this is because one of the common causes of opioid overdoses is when opioids are mixed with other substances, whether it's alcohol, other drugs, or sedatives. And so, right now, we're in the midst of an opioid epidemic. Sedatives are something that we're going to have to pay attention to in the years to come in terms of avoiding a benzodiazepine or sedative epidemic. A quick question for the group. How many folks in here have heard of Safe Med LA? Just by show of hands. Okay, great. More people than I thought. That's fantastic. I wanted to talk a little bit about what we're doing about the epidemic now that we've kind of framed the issue. And then I'll get into some of the signs and symptoms of addiction. So Safe Med LA is a broad cross-sector coalition that's taking a coordinated approach to addressing the opioid crisis as well as prescription drug abuse. We have a website that's highlighted here. The rationale for the coalition, and this is a coalition that involves public-private stakeholders, involves various county departments, involves LA City. The rationale for this is that we when we looked at the data and saw that we had increasing ER and hospitalization rates, we wanted to do something, and we found out there were a number of efforts across the county. Whether it was related to a medical task force that was focused on safe prescribing, an overdose prevention task force focused on naloxone access, pain management work group the Department of Health Services convened. Our LA Sheriff's Department also had safe drug drop-off boxes. But these efforts weren't necessarily coordinated. And so we saw the coalition's efforts as a way to coordinate these efforts so that they could be synergized and so that we were coordinating what we were doing. Another reason why we saw value in a coalition approach is because, as I had mentioned previously, opioid use is a community-wide issue. It's not simply a health issue. It's really a cultural and community-wide issue. And so for complex problems like that, we need to take what we like to call a blanket approach, where you address all the various drivers of the opioid epidemic simultaneously versus addressing one, two, or three at once. And the reason for that is because I like to describe the opioid epidemic as something like a carnival balloon, those long carnival balloons where you can kind of shape them into animals. If you squeeze on one end, what results is kind of a ballooning effect on the other end. And so a perfect example of this is safe prescribing, right? There's a lot of focus, particularly from the CDC, the Centers for Disease Control, around ensuring safe prescribing so that we're not over-prescribing opioids. And so we're starting to clamp down on the opioid prescriptions, which is oftentimes necessary and important. The problem is if we only focus on that and don't focus on alternatives such as medications for addiction treatment, then people who are already dependent on the opioids will oftentimes turn to other things like heroin. And so clearly, we're not wanting for people to stop taking their oxycodone so they can start using heroin, right? And so we need to give them a safe option and a treatment option to address that. And so, we saw an opportunity with a coalition approach where we're coordinating efforts across a number of different entities. This slide is just meant to highlight all of the various partners that are involved in this, whether it's within the county, including Department of Mental Health, Public Health, Health Services, LA Sheriff's, health plans such as LA Care, HealthNet and Kaiser, healthcare organizations, et cetera, et cetera. And so the point is, we're engaging a lot of people in this effort, and there's been a lot of interest to try to corral this growing public health concern. The work of Safe Med LA is guided by a 5-year strategic plan. This is available on our website. Our goal is to decrease prescription drug abuse deaths by 20% by 2020, and we take what we call a 9-6-10 approach. 9 action teams focused on 6 priority areas with 10 key objectives. This is the way that our coalition is structured around a central steering committee. And so you'll see on the top 2 on the left, there are 2 groups focused on safe prescribing in terms of medical practice as well as pharmacy practice. Pharmacists are oftentimes an overlooked but important health professional because they're the last ones to get opioid prescriptions before patients get their medications. And so they're an important intervention. There's an action team focused on medications for addiction treatment and naloxone, as Congresswoman Chu had mentioned. An action team focused on safe drug disposal. One of the most common ways in which people get access to particularly prescription opioids is from friends and family, oftentimes because, when we get a dental procedure, we get a month's worth of prescriptions. We may use 1 or 2 pills, and the rest sit in our medicine cabinets. And so having a safe and environmentally responsible way to get rid of our medications is important. We engage law enforcement, as I mentioned. This is not just a health issue. Law enforcement also play a role. LA Sheriff's Department, we're happy to see, recently implemented a naloxone program so that if their officers come across someone who they suspect may have overdosed, they have access to naloxone in order to reverse that, because sometimes police officers are the first on the scene versus paramedics, right? Oftentimes it depends on where an incident occurs. We have a data collection action team focused on getting data and feeding it to the different action teams so that they can make data-informed decisions. A team focused on cures, which is our statewide prescription drug monitoring program. And then lastly, a community education action team focusing on events similar to this event, where we can talk about why this is a problem, what we can do about it, and how others can contribute. And so this is a little bit about the work of the coalition. I'm not going to go through these 2 slides, but they're just meant to highlight some of the work that we've done through the coalition. We have trained over 200 new buprenorphine prescribers in the county. We've trained over 250 pharmacists so that they can furnish naloxone. We've distributed over 11,000 doses of naloxone through a California Department of Public Health grant. And so there's a lot of work and momentum behind this effort. And so I'm going to shift over to some of the signs and symptoms of addiction. Just starting off first with, what signs and symptoms actually mean. So signs are really the objective things that one can observe by looking at someone, whereas symptoms are some of the subjective things that someone reports. And so, signs essentially are things that you can see. Symptoms are things that you hear and report from the client or patient. Some of the signs that someone may be suffering from a substance use disorder include things like neglected appearance, changes in behavior, money issues, problems in school and work, particularly around relationships, as well as changes in terms of physical health issues. Anytime you have someone with rapid or drastic changes in these important life areas, it can be a red flag that something's going on, right? Whether it's a substance use disorder, whether it's a mental health condition, that we need to be paying attention and checking in with that person so that we can understand, what's going on. Some of the symptoms of addiction, so the things that we might hear someone tell us when they are starting to use substances, a fixation on getting and using substances. So just, it becomes a greater and greater portion of their time spent, right? Intense urges or cravings to use a drug, oftentimes that override other life priorities. Feeling like someone needs to use regularly in order to feel okay. Other things are like using more substances than intended for longer periods of time than intended. Continuing to use substances. This is probably something that many of us who have known people who use substances have observed or heard about. But continuing to use substances despite negative consequences, right? Whether they're financial consequences, social consequences, engaging in risky activities, right? Like driving, and also feeling unable to stop, right? At some point, oftentimes people realize, I think I'm using more than I really wanted to, and this is starting to cause some problems, and try to stop, and they realize that it's not quite as easy as they may have thought that it would be. The other thing that I like to highlight, just to make something that's somewhat abstract more concrete, is that they've done studies looking at the brain and looking at dopamine, right? How many folks in here are familiar with dopamine? That's right. One of the most important neurotransmitters in our brains, right? And so one of the keys with addiction is that it activates the reward pathway in our brain, which is what makes us feel good, right? When we eat cheesecake, when we have sex, when we do anything that feels good, sometimes including drugs as well, it activates that reward pathway. And on a typical day, our brain squirts out about 50 to 100 units of dopamine. 100 being like the best day you've ever had, right? You just got a promotion, a new car, all in the same day, right? Your brain will produce about 100 units of dopamine. On a typical day, it's 50, right? If you use tobacco, your brain produces about 450 units of dopamine, right? If you use heroin, it produces about 975 units of dopamine. If you use methamphetamine, 1,100. 1,100. So what does that mean? That means that someone who uses methamphetamine, after they use, their brain produces about 20 times the amount of that pleasurable neurotransmitter than what it normally produces, right? And so I like that example because it tells you why people use the metaphor of getting hooked on drugs, right? When your brain gets used to that much dopamine, even when it gets down to normal levels, let's say even it gets down to 100, right, which is, like I said before, like a really, really good day, it feels like it's not normal, right? Because your brain's used to the 1100 that it gets when they're using, when it's on methamphetamine. And so that's the problem that you run into when you start using more of these substances. Your brain gets used to higher levels of dopamine to the point where when you get down to normal levels, it actually feels abnormal. And you need to figure out, how do I replace that dopamine, right? And this is the same for a lot of other addictive substances or activities. But with drugs, it's artificially much higher than normal. And so I'm going to stop there because I know that we have a number of great speakers. I did want to at least highlight some of the resources that are available to you. In particular, I wanted to highlight the Substance Abuse Service Helpline. This is essentially the call center if you have loved ones, particularly those who are Medi-Cal eligible or Medi-Cal enrolled. You can call that phone number. There'll be someone on the other line to connect you with services. They'll do a brief triage screening to make sure that they can place you at an appropriate level of care. And also, we have a service and bed availability tool. There's a website there. This is essentially a web-based service locator that you can filter, just like you would filter through Amazon when you're looking for whatever you're looking to buy. You would be able to filter based off things like language, level of care, so whether you're looking for outpatient services or residential services, or specific service types, like if you're looking for services for someone who's a criminal justice client, who's perinatal, for example. And so that service and bed availability tool essentially includes all of the providers that we work with. And as you check off each filter, that list of providers will narrow so that you can find the provider who actually meets the needs of the client that you're, or the loved one that you're looking to get help for. And what this attempts to solve is the problem that we had before where people would just kind of Google or call around and see if people had beds or availabilities, because this service and bed availability tool also has information about if there are beds available or not. And so I just wanted to highlight that, and I will pass it off to our next speaker. Thank you very much.
Our next panel is supporting ongoing recovery, and that's going to be led by Leah Rodemick. Leah is the Chief Executive Officer and Executive Director of CASA Treatment Center, an addiction treatment program specifically designed to address the unique needs of women. Herself one of CASA's success stories, Leah has dedicated her professional life to paying it forward and helping other women recover, rising through the ranks at CASA to become its executive director. In this capacity, she has developed and implemented a comprehensive organizational strategic plan to expand services, raise the education level of key staff members, and ensure CASA's long-term fiscal viability. Cognizant of CASA's almost 50-year history in the recovery community, Leah has worked closely with key members of the community and program management team to develop additional programming that provides quality, ethical, affordable treatment to women seeking recovery from addiction. Help me welcome Leah.
Okay, let me see if I can figure this out. Where am I? Okay. Are you coming to help me? Thank you. Yeah. Beautiful. Thank you. Okay. Good evening, everyone. I want to thank Congresswoman Judy Chu's office for putting this together and allowing me to speak, and especially for bringing the topic of recovery to the table, because I think that often, especially in the times of crisis and epidemic, we focus on the problem, and the reality is there's very much a solution, right? So I'm happy to be here, especially because recovery is awesome. I'm in recovery. I see people recover all day long. It's a great topic, so I'm glad to be here. But before I talk about how to support a person getting into the recovery process, I want to give a little information of how addiction happens in a person's life. Because I think when we're thinking of this epidemic and this large-scale deaths, it's hard to connect with on an individual level. And the reality is that addiction is very normal, especially in America. You saw the amount of drugs that were prescribed. We are an addicted America. So we need to normalize that. And in order to normalize that, then we can make change. So that's what I'm hoping to do here. There is going to be some crossover, but it's different. So where I'm going to start is the basic definition of addiction, right? American Society of Addiction Medicine says that it's a primary chronic brain disease of the reward, motivation, and memory circuitry, and that it manifests in psychological, biological, social, and spiritual dysfunction. Now, that's medical terminology, but what does that mean, right? So that means your brain gets affected, and when your brain is affected, it looks like you change your behaviors in the outside world. That'd be the easiest way to look at it. So before I go forward, I want to do a little call on the audience. I want everybody in the room to think about, and I'm going to speak on alcohol because I think alcohol you can all connect with, right? How many of you think about the first time you had a drink? Now, was that with family or was that in a social forum, right? So from a show of hands, who was your first drink? Was it with family? Who was with friends? Okay. Now, one more show of hands. How many of you was that a pleasurable experience? I'm guessing if you still drink, it probably was, right? So that's what we see when we're looking at addiction treatment. We look, usually the first introduction to any substance, is usually through a family or a social norm. And what happens over time, you register that as either reward or relief. And when you're finding pleasurable experiences in life, what do? You want to have more of those pleasurable experiences, right? So it's really, really simple to continue going forward. What I've done today is you'll see in the next slide, I've broken the drugs into 3 categories. Now, and I've based them based off of how they're viewed socially, American socially, right? So the types of substances. First is tolerated substances, alcohol, nicotine, now marijuana. Symptom alleviating substances. These are the ones that we are prescribed or we buy over the counter. And then there's prohibited substances. These are the ones that we consider street drugs. Now, they're all addictive, right? But socially, we view them differently. If you're using the prohibited substances, you must be a drug addict. If you're taking symptom alleviating substances, it's more than likely because it's prescribed. But intolerated substances, most of us, if you're like me, I was drinking at 12. So those are just what we do socially, and it becomes socially acceptable. So when it's socially acceptable, that means it's a norm. It's normalized. And even when you're using the symptom alleviating, sorry, I'm pointing that way because there's another screen. When you're using symptom alleviating substances, what you're finding with the opiate epidemic right now is that people are using symptom alleviating substances in a way that the prohibited use people use it, right? So it's prescribed medication being used by what we would call drug addicts, but the reality is you're all addicts. That's just the way it is. So then what I've done next is I've talked about the stages of addiction. Now, I really wish that I hadn't made this slide looking like arrows because it doesn't necessarily occur in a timeline like that. Next time I do it, I'll make it bubbles. But so these are the different types of use that a person has, and you can actually experience addiction symptoms because if you remember, addiction is a manifestation outwardly of what your use is. So you can be using or abuse. Now, abuse category, anybody who's using those prohibited substances, or even if you're using the symptom alleviating substances in a way that's not prescribed to you, you automatically fall into the abuse category. There is no normal use of those drugs. Tolerance happens in your body when you start to use it over time, like Dr. Sai was mentioning. You start to use more, and when your body develops tolerance, because you're no longer achieving that same pleasure from it, you start using more just because you want to get back to that original pleasure center that you were trying to achieve in the first place. Now, what happens is when you do that over time, your body becomes physically dependent. Now, the tolerance and dependence is going to change significantly depending on the types of drugs that you're using. So specifically with this opiate epidemic, what you're saying is a high level of dependence, right? And what happens when you're physically dependent is you are actually not getting high anymore. When you're physically dependent, it is not a pleasurable lifestyle. You are simply taking the drugs to not feel the withdrawal symptoms, right? So I can say that because I used to be an opiate addict. I'm 14 years in recovery now. But by the end of my addiction, all day long I was doing opiates, right? And I knew the drug was the problem, but every time I went to quit, I would get so physically ill that I didn't have a choice and I had to take it because I still had to go to work, I still had to go to school. So I think sometimes when we think of addicts, we only view them through this lens of like the homeless population. But I can tell you it's not, right? I was fully functional. I was working, going to school. Of course, I had I had the other stuff, but still fully functional and still 100% in my addiction, right? So don't be confused and think that just because this person looks normal that they don't have a problem. They probably do. Catalyst to increase use. Now, what happens in our lives, and everybody's lives, there's things that go on in our life that cause life stressors. They cause crisis in our own life. And generally what you'll see, especially if you're an alcohol drinker, if you're going through depression or a simple life crisis, you're probably going to drink more on those occasions, right? Now, if you happen to be using one of those other substances, same thing is going to happen, just the consequences are going to be worse. So what are some examples of catalysts that would increase your use? Really simple, and I bet you guys can identify with a lot of them. There's medical conditions. Like maybe you had a surgery, right? The surgery, they're going to prescribe you pain medication afterwards. And you know what happens after you've been on that pain medication for a long time? You're going to be dependent on it. And then that's going to spiral out into something else. Life accomplishments. It could be maybe you got a new job and you're suddenly part of this new class bracket and they all socialize and they do different things. It's going to be different for you. Family system disturbances. Are you going through a divorce, a breakup? All of these things cause stress in your life. Financial issues, and I'm sure we're going to be seeing a lot of this here in LA County pretty soon. Like, is there a job loss? Can you afford your rent? All of those types of things. If you have multiple of things of these going on in your life, it's very hard to cope and manage. Then if you have an addiction on the side of that, life can become overwhelming, right? It's really hard to, if you have medical conditions, you're going through a divorce and you're having financial issues and you can't stop using your drugs, you almost don't want to stop using your drugs because life sucks, right? There has to be an alternative that's better, and when your life is this way, there's no reason to. So, creating a life in recovery. This is the fun stuff. So when a person comes to treatment, before they go to treatment, what we look at is their substance abuse history, but we also look at what else they have going on in their life. And based off of those things, in addiction treatment, we don't look at, it's called substance use disorder, and it's based on a severity scale, right? So some people are going to be more severe in their addiction than others, but that doesn't mean you don't have addiction. It just looks differently for everyone. So if you have a family member who has a substance use issue, you're going to see their drugs are creating this chaos around in their life. But what the addict sees is that their life is chaos and they have to use drugs because of it. So if you can see the difference in that lens, that's why they stay there. So if you have a person who needs help, the best approach is don't focus on the drugs directly. You're never going to get anywhere. If you're sitting there saying you need to stop drinking, your drinking is your problems, you know what they're going to say? Well, you did this, this, and this, and this is why I'm drinking. And there's no way around that. So if you are going to approach a family member, the best thing, number one, whoever is the person in the family that has the best rapport with that person should be the one to approach them. If you're the one who they're constantly combating, you're not the right person. They're never going to be open to your assistance. So the person with the best rapport, come to them and say, listen, I see you have all of these things going on in your life, and I also see that you're drinking or using more. If you need help, I can help you, and I'm willing to help you do that. Right? So offer it as an invitation. I know that our old approach to addiction was always very confrontational and consequences-based, and we don't really do that approach anymore. Because this is the problem, is that it should be normal. Everybody has life crises, and you can go through phases of your life where you come in and out of addiction spectrum, and it should be totally okay because it's normal, because everybody has it. Not everybody. I'm sure none of you have any problems, right? Okay, so if you're wanting to get somebody in, one of the options is to get them into addiction treatment program. There's different levels of addiction treatment programs, and those are all based off of the person's severity, which I was telling you earlier. So the initial spot to start would be detox, and detox is very, very important, especially if you're coming off of opiates or alcohol. The physical withdrawal symptoms can be very hard, so detox helps with that. And usually when you're in the detox facility, they will give you referrals and guide you to the next level of care. The new approach for opiate use is to use medication-assisted therapies. Now, if you have a family member, here's what I would do. If you need somebody who you think might need treatment at some point, do your research now. Do the research before you're in crisis. Because if somebody comes to the point where they're actually willing to say, yes, I need help, I'm telling you that window stays open for a very, very short period of time. If they come to you one day and say, listen, I really need help, if you give them 3 days where they're able to not drink and use on their own, all of a sudden they're like, oh, it wasn't really a problem, right? So you need to jump on that because they will do it again. It's just the cycle. So the way to investigate treatment centers, number one, ask around to your peers, your coworkers, your family members. I guarantee you somebody else has a family member who's had to deal with this as well. You are not alone. And then also contact your insurance company. Find out what benefits are covered. Find out who's in network. And then call those programs. Find out about the programs. Find out about what they offer. Number one, ask if they have a family program and if they have an alumni program. If they don't have those things, they're not doing enough work. Your people shouldn't go there. Those are very important pieces to ongoing recovery. Now, if you don't want to do addiction treatment, there are other options, recovery support options. There's coaches, there's peer, you could do individual therapy, social worker. There's also religious communities or self-help groups. All of these things give you new tools and skills for living life, but they also give you a community of people who are going through the same thing so you feel understood in the process. Same thing goes for family members. Just because your loved one is the one having an addiction problem, you're affected by that too. It's not easy to deal with an addict, and I'm sure they've done some major consequences or damage in your life, so it's not always easy to help them, so you need support as well. Interventionists can help you deal with the addict that you're trying to work with, but family therapy, individual therapy, and even 12-step programs for you. They're great to help you build new tools and skills for how to deal with your loved ones, and they also give you a community so that you don't feel alone through this process, because addiction can be isolating for both the addict and the family members that are having to deal with it. And the most important thing in my mind is that this is normal, and we all need to be able to talk about it because that's the only way we can ever get to the solution of recovery. So that is my pitch for tonight. My only thing I'm saying is recovery is possible. So thank you.
Thank you, Leah. For our next presenter, Theo Krizwicki. He's a paramedic and founder of End Overdose, an organization committed to preventing addiction-related death through education, medical intervention, and public awareness. They connect communities with necessary resources to fight chemical dependency. End Overdose is focused on mobilizing the nation to respond to drug overdose and save lives everywhere. Theo's presentation is going to be on identifying and reversing overdose. And on a personal note, Theo's one of the first people I met 3 years ago when I got sober. He is a person living in long-term recovery, I think now for 7 years. About, 6 or 7 months ago, Garrett and I were involved in some work, and Theo came in and said, how do I get involved? I'm a paramedic. I think everybody should have Narcan. And we sat down at a dinner table and we said, start a nonprofit. And so that's exactly what he did, and he does this work every single day. So please welcome Theo.
Hello, everybody. How's everyone doing today? Good? Okay, good. We're going to figure out technology. Oh my God, you're here. Thank God. I was really worried. I was like, I'm a paramedic, but I don't know how to do this. I'm this one. Yeah, I'm the scary one. Yeah, we're serious. Very serious things are going on here. Oh, that's not good. That's not how it's supposed to look. But hey, that's what we're rolling with today, guys. So my name's Theo. I'm a paramedic. I've worked as a paramedic in Los Angeles County, and I also work in Riverside County. And for us, overdose is a very big problem. We respond to it almost every single day. But it's actually a very routine problem and pretty simple to fix. When I come on scene, I'm not very worried. It's a very routine call. we give some intranasal Narcan, and most of the time we revive them if we get there on time. Just a quick story, a couple stories are, I arrived on scene just the other day to a man overdosing in his car in front of a drug treatment center. How ironic, right? He was cold, he was pale, and he wasn't breathing. Everyone was standing outside of the car. There were about 5 people looking at him just like, hey, thank God you're here. Now, the harsh reality of this is had I not arrived within about less than 7 minutes, we were very close, this person would have suffocated and died while people stood and watched. Now, for me, there's no reason that should happen. So, in the last, Gary went over this, in the last 2016, there 64,000 people died of drug overdose. Right now, it's the most common thing to kill people in between the ages of 22 and 50. The most likely thing that's going to kill you is going to be a drug overdose. And for us, just what our goal is to really just combat the opioid epidemic. There's a lot of prevention, which is really great, but what we focus on is going out there and making sure every single person knows how to respond to something. Because there's no reason someone should die, right? You don't need to wait for a paramedic to do something to save someone's life. That's crazy, right? You're all people. You guys are strong, yeah? Okay, yeah, there it is. And we have the craziest thing about this epidemic is it's not like, like Ebola. Right? What's the cure, right? We know the cure, right? If someone stops breathing, you breathe for them, all right? It's pretty simple. And not only that, we have the antidote. We have Narcan and naloxone. It reverses the overdose. This is crazy, right? So where there are drug addicts, where there are people using the drug, we should probably have the medication that'll reverse the overdose. Pretty reasonable, right? So that's what our philosophy is. We go out and we do that. It doesn't cost me anything to train you how to do this. It costs me $0, okay? And it's a really simple process, right? We're going to go over it tonight. Now, I just wanted to mention this. We have this in the back. You can take it out, print it, give it to your friends. And it's just a flow chart of how to respond to an overdose, right? Really useful, especially in times of panic, right? So we'll just go over a couple things real quick. That's right. I see Leah's problem here, right? There's 2 different things going on. This is crazy, right? Confirming and having that general impression of an overdose, right? So it's really not that difficult to notice. Look around you, right? All these people are healthy, they're alive, they're talking to you. We know what normal looks like, right? Some of the things that you can see right off the bat is a blue tinge to the skin, right? Or the nail beds, or maybe they're pale, right? And that blue is kind of a scary symptom because it signifies that the blood isn't getting oxygen, okay? But for a paramedic, I'm like, good. I know what the problem is. He's not breathing. His skin is blue, no problem. We're going to breathe for him. He's going to come out of that, all right? So things to look for is you get in there and you're like, oh my gosh, what's going on? This person's blue. Probably a bad sign, right? They've got pale skin or they're breathing really shallowly, right? Maybe you can barely notice they're breathing, and a big problem, right? So based off of that, let's go ahead and do a press there. What do you think? Is that person overdosing? How simple was that? That person's overdosing. Now, not all the times you're going to not always get that paraphernalia there. You're not always going to get a syringe needle handed right over there. But you can have a fair idea when someone's not talking to you, okay? When someone's skin looks different, right? When they look sick, when they look pale, when you hear gurgling. These are all signs. And so once you hear that, call 911 right away. I'm a paramedic. It's going to take me at least 7 minutes to get there. If you do not breathe for 7 minutes, you're dead. All right, just the other day I went to this woman's house, all right? Actually, this was when we used to work as a paramedic in Los Angeles. I went to this woman's house and we got to her house. We were about 10 minutes out. We were at the longer end of the spectrum, right? And she got there and she was holding her son, okay? He was my age at the time. I was 23 years old. I've been in recovery. I've been sober for about 3 years. So it was me. And she was holding him and we started CPR. And we worked on that kid for 20 minutes. And I knew when we got there, he was dead. Because I knew how long he had gone without oxygen. And the thing about it is that mom could have saved him. She could have. She could have saved her son. And I know this disease affects everybody that it touches. And it's not just young people that are using it. It's not just people on Skid Row. I grew up in Seattle, Washington. It's very rainy. I was a heroin addict out there. And I live in sunny California as a paramedic. Kind of a weird transition there, right? That's kind of fun. But if people are given the tools, they can prevent this. They don't never have to go through that, right? This happens to grandma at the nursing home who had back surgery, and she's given a fentanyl patch. She doesn't want to, overdose. She just, they're old. She just put on a fentanyl patch. All of a sudden, grandma goes into respiratory arrest. This is a big problem. We want to save grandma, right? So once you recognize the overdose, give us a call, and we'll start into the other little pieces here. So some of the things that you want to do is you just want to assess their airway, their breathing, and their circulation. This is it sounds like a lot, but it's really not that much, right? Is their airway open? We're just talking about this area right here, right? Do you hear snoring? Do you hear gurgling? If you hear those sounds, those are bad sounds. Listen to everyone breathe right now. You don't hear anything. If you hear something, it's not a good sign, all right? If they're breathing, you want to make sure you'll see chest rise and fall with that. And then do they have a pulse? You want to check a pulse, make sure they have it. If someone doesn't have a pulse, do CPR, right? Do chest compressions, 30 chest compressions to 2 breaths, right? How do we get this here? There we go. So looking to breathe, responding and checking someone if they're breathing or not, a great way to do that is this method right here. Look and listen, right? I like to use the images because it gives you a better feel than a bunch of text, right? You can feel them breathing out, and you can see their chest rise and fall. And that motion right there, that simple activity, is going to allow you to do that, right? Feel for a carotid pulse, right? We've got the image. It's going to be right here. It's a fun way to practice is just practice on yourself, right? You don't need me to come to your house and show you how to do this. You can just find it yourself and then just practice that. Be like, where is that thing, right? How am I going to find that on Dan today? You know what I mean? Just in case, right? So we'll go there. And if they're not breathing, we're going to start rescue breathing, all right? So real simple method that we use in EMS all the time. It's called the head tilt chin lift. It's very simple. It opens up the airway, pushes the tongue into proper order, and it gets you into that airway, which is the trachea, which goes down to the lungs, and allows you, when you give a breath to that person, to go right down in there and give them that life-saving oxygen, all right? You're going to pinch the nose shut. You're going to form a tight seal around that person's mouth, and you're going to give them 1 breath every 5 seconds. So if you come to someone's house, you notice that they've overdosed, you notice that they're not breathing, but they still have a pulse, hey, no problem. Call 911, come over to that person, do some mouth-to-mouth, 1 breath every 5 seconds. It's going to be a long time. You're going to be with that person for 7 minutes, but they're going to thank you when they wake up, all right? Moving on, that's just kind of what the head tilt chin lift looks like. You put your hand on their forehead. Can you guys all go like this? Just do this motion. How simple, right? We can all do this. We can all do this motion. You touch their forehead, you lift underneath their chin, you move it like a lever. Hey, look at that. We just opened someone's airway. No need to panic, everybody. And you can see the anatomy there. You can see how when their chin is down, it doesn't really open up that airway. When you move their head back, it does, right? So we get to see the blockage removed there. Very simple stuff. Mouth to mouth, same position, head tilt chin lift, forming a tight seal. And you're just watching for the chest to just rise a little bit. 1 breath every 5 seconds, right? There we go. So we'll talk a little bit about Narcan, right? Narcan is a very simple thing to use. It's classified as a competitive antagonist medication. And what it does is it actively displaces any of those molecules, those opiate molecules that get on a neuron and cause respiratory depression, right? And we'll go over the physiology there, right? Oh, look at this. We got some animation. If you look over here on your left side, you'll see basically what happens is these opiate molecules that get right down onto a neuron, right? And think of it like a weight, right? Once you get that opiate receptor on there, it's going to push everything down, and it's going to slowly cut off your cognitive function. You're going to get sleepy. You're going to get woozy. You're going to have that classic opiate nod, okay? And then what's going to happen is that person's going to go unconscious. The next thing that's going to happen is they're going to stop breathing. The final thing that happens is they go into cardiac arrest, and if no one intervenes, they're going to die, okay? So what Narcan does is a pretty cool thing. We inject it intranasally. It's a very, very easy thing to administer. You don't need a needle at all, right? All you need to do is apply that medication. It's going to seep in, and it's going to go right to those neurons. It's going to knock the opiate receptors, those things off, and it's going to create this protective barrier, okay? And that's really great because what's going to happen is this medication lasts for about 30 to 90 minutes, and it ends up reversing that overdose, all right? So it really is an antidote. It's not a permanent fix. what you need to understand is see how we have those molecules kind of like off in the distance, right? They're just going to kind of hover around. Think of Narcan as more of like a force field, okay? So that person is going to be okay, but that doesn't mean like just leave them off and just leave them at home. Still follow up with the hospital, still send them out there, because what will happen is eventually that medication will wear off, that force field will go away, and that opiate will come right back down, right? So it's an amazing drug, and it reverses that overdose. It allows them to start breathing spontaneously again, which is amazing. We show a very simple way to administer the drug. It's kind of like using Afrin, okay? You're going to take the box, you're going to open the box, you're going to put it in their nose, you're going to squeeze the plunger, and it's going to do its trick, all right? It's going to work in about 3 to 5 minutes. And that's why we start with rescue breathing first, okay? It is an adjunct to your response. The main killer to people in opiate overdose is that people don't do anything, and they don't know what it looks like, and they don't breathe for them. They just stand there. And so what we do is we go and we make sure you know what to do, just like this. Very simple, right? And then what you're going to do is you're just going to watch for an effect, right? You're going to continue on with your treatment. You're going to continue to rescue breathe. You're going to notice for any changes. Changes that you'll notice is maybe they'll kind of start breathing back at you. You'll get this kind of spontaneous hot air in your mouth, which is a weird feeling if you've never done it before, but hey, it's good, right? And you're going to notice their color come back to them. How many of you guys have seen Pulp Fiction? So, you know when they get Uma Thurman, that's not how it works. They don't just like, hey, how's it going, right? Hey, everybody. It's usually not the case, okay? You're going to give that medication, and they'll probably start breathing in. You'll feel them start breathing in. You'll see that color come back, and then you can stop breathing for them because they can breathe for themselves and wait for the paramedics to arrive, right? However, they may go into withdrawal. That's kind of what it looks like, right? So one of the things that you do with Narcan is you put an opiate user into withdrawal, which means they get kind of sick. They don't feel great, right? They're alive, but they don't feel great. Narcan's not like you can do heroin and kind of shorten it up with some Narcan and like get your high longer. It's one or the other, baby. And once that heroin's off, you don't feel good, okay? And that's fine. We don't care about that. We just want you to live, right? So the things to expect is they may feel a little queasy, they may feel a little nauseous, maybe they vomit. And if that happens, turn them on their side, put them in this recovery position. This position is for when they start breathing again. Maybe they're not 100% conscious and looking at you. You put them on their left lateral side. The reason we do that is a real simple way. It keeps their airway clear, it keeps it open. We put their hand underneath their head, it supports their head, keeping that open, and their knee stops them from rolling over, which is a really important thing. And to really explain it is because of this anatomy right here. When you're on your right side, what's going to happen is you're going to flip the stomach over. It's going to cause all those gastric juices to kind of like seep out the esophagus into the mouth, and it's going to actually increase the risk that they'll vomit, choke on it. So we don't want that. You turn them on the left side, it's just kind of like a bowl. It keeps everything, the anatomy in there real well. So we really like that image. And basically, that's really it. So those are the key steps to responding to an overdose. We have the flow chart on the back. If you want to get some Narcan yourself, we actually have a Narcan finder on our website. Just visit our website, go to the page, what is naloxone, what is Narcan, and there's a Narcan map. You can pick it up at your drugstore with a standing order, which is pretty cool. So that's all we have here. We'll turn it back over to Ryan. Thank you so much.
And just like Theo said, it's really important to know, so what he said, there is a standing order for Narcan in this state. What that means is that you can show up anywhere, any pharmacy, without a prescription and get Narcan. And I would suggest if you have a loved one who has an opioid use disorder, or a friend, or a neighbor, or it is anywhere near you, to go ahead and pick up some Narcan and just have it on hand. I can't tell you how many friends that have died as a result of not being able to, folks not being able to respond to an overdose quick enough. So it can save a life. We now have a couple of questions for the panel. The first one is for Dr. Tsai. This topic is very important to the American Cancer Society Cancer Action Network, which aims to eliminate cancer as a major health problem. We want to ensure that individuals diagnosed with chronic illnesses are provided access to pain medication that they badly need. How is Congress discussing and differentiating between addiction and those patients with a chronic illness?
So, oh, mic on this one? Can you get? Okay. So I think this question is focused around, there's a lot of effort right now being placed on ensuring safe prescribing, right? I had mentioned this previously. And specifically around prescribing opioid pain medications for acute conditions as opposed to chronic conditions. Chronic conditions are things that aren't going to go away, right? Like low back pain oftentimes, arthritis, right? These are things where if you take opioids over time, you're going to need more and more opioids because your body's going to become more and more tolerant to it. And so what the CDC has recommended is that we not use opioid pain medications for chronic pain. We only use it for acute pain. Now, the caveat to that and how it relates back to the comment from the American Cancer Society is that the safe prescribing guidelines are focused on non-cancer patients. And so with cancer, it's a little bit different. And so, I know that there's a lot of discussions around safe prescribing. The question was specific to the federal level, which I think Congresswoman Chu would be in a better position to answer than me. But I also know that a lot of those conversations around safe prescribing are around non-cancer patients.
Thank you. Next question is for both Theo and Leah. Is harm reduction approach effective in reducing drug dependence and use? I guess we'll go with Leah first.
I would say there's not enough evidence to talk about that at this forum yet. There's not enough evidence behind it.
What we've does this thing work?
Absolutely.
Is this doing good?
Yep.
Excellent. I've noticed that I've seen fewer overdoses in areas that are using methadone. Just as a paramedic, I can only speak as a paramedic, but I've noticed that it creates less of a chance for them jumping back at their full dose and then going into a full-blown overdose and respiratory
Actually,
arrest.
can I take
Yep.
that back? One more
Yep.
thing. The reason that's a challenging question to answer is because it depends on your measure of success, right? So what are you measuring the effect, like death? Okay, so they're not dead, that is one. But the other thing would
Infectious diseases also.
Right, infectious diseases, yeah, that's good. What I would say is there improvement in the person's quality of life? And if there's improvement in the quality of life of the person, regardless of their approach that they're using, then who cares?
Dr. Sai.
Yeah, so I think an important consideration here is what you define as harm reduction. From my perspective, I think oftentimes there's this false dichotomy between social model and harm reduction or the medical model. And so oftentimes, traditionally, people group things like medications for addiction treatment, which are FDA-approved medications for the treatment of addiction, as well as things like naloxone with harm reduction. And so I think that according to studies from the National Institute on Drug Abuse, there's significant evidence to indicate that medications for addiction treatment are helpful, help improve outcomes, help improve treatment retention, help improve time to relapse. And as Leah had mentioned, the first thing to improve quality of life is that someone's alive, right? If they're not alive, well then there's no way you're going to be improving their quality of life. And so I think that there's absolutely evidence to support medications for addiction treatment as well as the use of naloxone. Whether we want to call it harm reduction or not, to me, is less important. I think all of us in this room care about people living with substance use disorders. We all want them to get help. I think there's different ways that people get help. Some people do good on medications for addiction treatment, other people don't. And so what we want is kind of as many tools in our toolbox as possible to help as many people as possible.
And so the final question here is from somebody here in Pasadena. Are you concerned with the abuse of these alternative opioids? I believe they're referring to MAT, or their use hampering recovery. Recovery depends on developing new pathways in the brain and The drug buprenorphine feeds the same one. And if I can just take a personal liberty to answer this question first. I am a product of medication-assisted treatment. Medication-assisted treatment saved my life. I was on it for almost 10 weeks. Had it not have been for medication-assisted treatment, I probably would not be standing here today. I would be 6 feet under. So MAT, when used appropriately, in my opinion, does save lives. It is not a magic bullet. A lot of people think you can just take buprenorphine or methadone, and that's it, and go on your way. I think the panel and Dr. Sy can attest that MAT needs to come with wraparound behavioral health supports, which include recovery supports, adequate housing, but it does save lives. It saved my life, and I'll pass it off to the panel.
Does this thing work? Okay, great. What I notice markedly is just that when I respond to someone that is overdosed, a lot of the times maybe they're going into a detox facility, maybe there's someone at home, and we get a chance to talk to these people if they come around, but they're someone that is either, in my personal experience, I can only speak for that, this is someone that has just recently gotten sober and then gotten back to using, and they go right out, and anything that inhibits that, I'm happy to not respond on you, right? So there's a lot of medications out there. We learned about one, Vivitrol, which is amazing. It's an injection medication. And I think with Medi-Cal, they get it for like a year, right? That's a 1 year, and it prevents you from using and getting high off of an opiate, which is amazing. That gives you 1 year, which is a long time. So yeah, it's pretty amazing.
And I also think more recently that there's been a trend to move away from, I'm going to say it wrong, Suboxone, how do you guys say it?
Buprenorphine.
Yeah, that one,
yeah.
that one.
Yeah.
That because it has become a secondary issue for people in recovery, and I know that they are moving towards the other alternatives to that, using non-addictive medications in some form.
So actually, at the county, we're trying to expand access to all forms of medications
Even
for
the
addiction
buprenorphine?
treatment, including Suboxone or buprenorphine, including long-acting naltrexone, also known as Vivitrol. I think there absolutely is concern about people abusing medications, particularly agonist medications like buprenorphine or methadone, because those medications are abusable. Right. That's one of the reasons why, before they're prescribed, there's a careful assessment by the prescriber, there should be, about who you're prescribing this for. And you want to prescribe it for people who are at a place in their recovery where they're ready for medications for addiction treatment. If they're just in the beginning phases and they're still considering whether or not they're actually interested in treatment, that probably is not the best time to start someone on this. And so I think that there are a lot of clinical considerations that need to be made before you ensure that someone's appropriate for medication for addiction treatment. And there are also considerations unique to that individual about if it's something that you want to start on someone on. But as Ryan had mentioned, for some folks it is life-saving.
I'm going to put a pin on the MAT discussion for a second. There are many different ways that people find recovery. Medication-assisted treatment is just one of them. There's abstinence-based recovery. There's multiple pathways. There's not just one way to do this thing. Next question is, what all are the alternatives to opioids for pain? We take if because of chronic pain.
Yeah, so some of the alternatives to pain are things like physical therapy, heat therapy, massage, cognitive behavioral therapy, mindfulness. I mean, there are a lot of things that the CDC is recommending that physicians and other healthcare providers consider before they start someone with chronic pain on an opioid pain medication. And I think that there's increasing focus on that. Just to highlight, because I know that this is a common question about cannabis, because obviously after Prop 64, cannabis was legalized in California. There are definitely some studies that indicate that cannabis can be helpful for pain. I think the challenge with cannabis right now is that we're in a position where we need to make policy decisions before the science is there. And what I mean by that is because cannabis is a Schedule I drug at the federal level, there's been limited studies on it. And I think even using the term cannabis, I'm not a fan of, because the reality is that we're talking about a plant, and that plant has two active ingredients that people tend to focus on, right? THC or CBD. Those active ingredients have different actions and biological actions on the body. And actually one has been shown to be potentially therapeutic for a number of things. Another one is psychoactive and has been shown to be detrimental for a number of things, including decreasing the age at which people can experience some psychotic symptoms. And so I think that as we move forward with the science, we'll be able to start talking about cannabis with more precision in terms of THC or CBD. And once we're able to do that, we'll be able to determine if that's something that can be helpful for something like pain.
Great. And the last question is, are there any contradictions of using Narcan if it is used on someone who is not having an overdose, such as the first person arriving, it is unknown to them, and they give them Narcan?
No, but if they wake up, they may be a little mad at you. You put something in their nose. That's it.
Great. Help me thank the panel. And thank you, everybody, for coming out. I'm sure the panel will be around to answer any questions afterwards. Thank you.